4-year-old girl who presents with infrequent passage of stools for 3 months. Whenever she tries to pass stool, she strains a lot. She crosses the legs, cries, and sometimes she passes pallets. But when the parents examine the child's undergarments, there is soiling of clothes, and this all has been happening for 3 months, and the swelling of clothes have started for last 1 month. There were no symptoms in infancy. The child has been neurologically normal with the normal anthropometry and normal growth. And when examined, the only examination findings are there are abdominal lumps of various sizes in right iliac fossa and left hypochondrium.
So can we have a comment from the participants? What could these lumps be? What could these lumps be? See, you first have to listen to the question before answering. Fecalith. So obviously everybody says, Dr. Dheeraj, that these lumps are fecaliths. Over to you, back again.
When you said that these are fecaliths, then the diagnosis is very apparent that you are dealing with a child who is having constipation. In a constipation child, you need to diagnose whether it's a primary cause. That means that it's a idiopathic kind of constipation, or what you call a functional constipation, or there could be secondary causes. So first of all, I would like to ask from you, what are the secondary causes of constipation?
Please type the secondary causes of constipation. Hypothyroidism, Hirschsprung disease, Hirschsprung again, hypercalcemia, celiac disease, cystic fibrosis, inflammatory bowel syndrome. So these are the ones, tuberculosis, these are the ones that secondary causes have been listed.
Okay, thank you. So most of the important secondary causes, like I would say hypothyroidism, Hirschsprung disease is very important, and then it could be related to the anatomical malformations of the rectum and anal canal stenosis, rectal stenosis, ectopic anal canal. These could be the causes. And hypercalcemia is an important cause, especially if the child has been consuming inadvertent high doses of vitamin D. Very good. Regarding inflammatory bowel disease and cystic fibrosis, they present more often with diarrhea rather than constipation. And constipation is not an important, although they may be listed in the lower down in the etiology list, but they are not important causes of constipation. Celiac disease, yes, celiac disease besides causing diarrhea can also cause constipation. So in this kind of presentation, again I'll come to whether this could be primary or secondary cause with this presentation, and why.
The answers have started pouring in. Primary raised to the power 4. Because no neurological signs, no signs in infancy, because the anthropometry is normal, that's why it is primary. More answers in favor of primary, going to the power of primary. Reasons also, please. Justification. At the age of transition of toilet training, it is occurring, that's why it is primary. So that's another reason. No other symptoms are there. What symptoms? Again, let's talk of the red flag signs. Here also you have red flag signs, no neurological signs. So there are no other symptoms, and we will talk about the red flag sign when Dr. Dheeraj will discuss how do you differentiate primary from secondary causes. Over to Dr. Dheeraj.
Thank you. So again, rightly said that it appears to be a primary or functional constipation, since there are no other clues. But I always say that even though this is the most common cause, primary or idiopathic, you need to have a detailed medical evaluation before you say that it is primary. So your detailed medical evaluation would include the history of any passage of meconium beyond 48 hours in the newborn period. If the constipation started in the first month of life, as was not the case in this child, any family history of Hirschsprung disease, because Hirschsprung disease is again has a strong genetic basis. If there is blood in stool without any anal fissure, that would suggest a secondary cause. Presence of failure to thrive. Any time the child has had bilious vomiting, If the abdominal distension is very marked, so that would suggest Hirschsprung disease or hypothyroidism as the cause. If there is any abnormality in the position of the anal sphincter or anal canal, because that, as I said, that ectopic anus and anorectal malformations could be the cause of constipation. And if any examination of the spine reveals any abnormality in form of tuft of hair or a dimple over the sacrum, it may be suggesting a spina bifida. And then if there are any scars over the anal region, again that may suggest an underlying or operated child with anorectal malformation in past. So these are all red flag signs you should look for, and if they are absent, only then, including growth failure. If growth failure is present, then you need to look for causes such as celiac disease and even Hirschsprung disease. But if nothing like this is present, you can safely diagnose this child as having primary constipation.
Dr. Dheeraj, there is a question: is PR examination warranted in this child?
Important question. PR examination usually does not help in such a case. Although the old gastroenterologists they used to think that PR examination is must, but now it has been proved that PR examination does not help in establishing the cause very often. So it is not required to be a routine part of examination in child with constipation. The only reason the PR examination may have to be done because there are diagnostic criteria for functional constipation, and one of the diagnostic criteria is presence of large fecal mass in rectum on PR examination. So if otherwise the child is not fitting into the diagnostic criteria and you need one additional diagnostic criteria for constipation, you may have to do a PR examination to see for fecal impaction. Or sometimes for relieving the fecal impaction also you need to do PR examination.
That is more commonly observed, that you have to do the PR to relieve the fecal impaction rather than for diagnostic purpose. Thank you. We go on to the next query, Dr. Dheeraj, from your side to the students.
So I would just briefly explain the chronology of events which are occurring in this child. So this child is having constipation, as rightly said, that it's the time when the toilet training has been started, probably because of some problems with the toilet training. The child started having constipation. The child had hard stools. Following hard stool, the child started having painful defecation. And when there is painful defecation, what the child does is that during the process of defecation, the child tries to there is voluntary retention of passage of stools. Parents feel that the child is straining to pass the stools, rather child is straining to prevent the stool from being passed, because the child knows that if stools are being passed, it will lead to painful defecation. The child tries to avoid the passage of stools by straining, by crossing the legs, like this child is doing, which leads to further absorption of the remaining water, further hardening of the stool, and ultimately the child develops fecal lithes and fecal impaction. So this is the chronology of event. And when there is fecal impaction, the liquid stool, which is proximal to the impacted stools, that slowly trickles down from the side and leads to fecal incontinence. So sometimes the parents get confused. They present that the child is having loose motions. So sometimes I've seen people recording this as a diarrhea. So this is not diarrhea. The swelling, the liquid stool does not mean diarrhea. The liquid stool is because of the trickling down of the liquid portion from the anal canal. So that is not diarrhea. So the child will clearly give a history of constipation and difficulty in straining. When there is swelling, it is because of the passage of liquid stool. So this is the chronology of events in a case of constipation. And while planning treatment, we need to break this cycle. Unless you break this cycle, the training, by training and by relieving the child of painful defecation, the treatment will not be successful.
Yeah, Dr. Dheeraj, there is a query. I think it must have been resolved by now, because you have explained very beautifully the chronology of events. Why is soiling occurring for 1 month? Is it because of sphincter dysfunction or due to hard stools? Prachi asking this question.
Yes, I've already explained that the swelling of clothes is late in the chronology of events. Previously, the child had hard stools and painful defecation when the child started retaining started avoiding passage of stool, becomes further hard, impacted, and finally it is because of the trickling down of the liquid pieces. It is not because of the primary sphincter dysfunction. But remember, when the anal canal is all full of fecal mass, then there is the anatomical physiological dysfunction starts happening. The rectum is distended, the sphincteric malfunction, which is secondary, not a primary sphincteric malfunction, that also starts happening, and that leads to further worsening of the incontinence. So I would say that it's a mix-up of the two. It's because of the impacted hard stools, which ultimately may lead to intestinal dysfunction, including that of sphincter.
So students, I think you have very clearly now understood that this is a primary, as we have already diagnosed, this is a primary constipation, and none of the red flag signs were highlighted by yourself or Dr. Dheeraj are there. So now you have to investigate for this child or work up what all investigation you are going to do. Be careful answering this question. Yeah. So what is your workup? You can start typing in your chat box. What is the essential workup you would like to do? Stool examination, X-ray abdomen, thyroid profile, thyroid. Are you considering secondary constipation in this case, or you had already diagnosed it to be a primary one? Stool for occult blood. Okay. Over to Dr. Dheeraj.
So again, the same is true.
Last answer is no investigation.
Yeah. So the same is true for constipation as was for chronic abdominal pain or functional abdominal pain, or if on history and examination, that should be careful history and careful examination. If there is no clue towards it being secondary cause, no investigation is required. The routine testing for thyroid, celiac disease, as well as for Hirschsprung disease is not warranted. If there is no red flag signs, if there is no abdominal distension, no failure to thrive, no anemia, workup for celiac is also not required routinely. So the workup will depend on the presence of red flag signs. And remember, when we say that we have this cause and that cause in constipation, most often we just do a battery of tests without carefully considering that we have missed some red flag sign. That is why sometimes they turn out to be having a cause. Definitely it will be warranted if there is any red flag sign, including growth failure. Otherwise, no test is required, but a careful examination, including the examination of spine for presence of any tuft of hair or dimple, is required. If you miss that, you are going to miss the neurological causes of. And if there is any lower limb tone abnormality, any problem in the reflexes of the lower limb, including the ankle jerk, definitely you will like to evaluate for a neurogenic cause.
Dr. Dheeraj, another query: what is the usual presentation of constipation due to congenital anomalies?
Due to congenital anomalies, it will depend on the type of anomaly. If the anomaly is, you are talking of anorectal malformations and anal stenosis, there would be presentation right from birth, the child passing the ribbon-like stools right from birth. For if you are talking of neurological malformations like say Hirschsprung disease, there would be predominantly abdominal distension, which gets relieved on passage of stool either spontaneously or after rectal stimulation. And if you are talking of abnormalities of the spine, then there would be abnormalities in bowel as well as bladder. It would be urinary retention, as well as the child would not be passing stools even after straining.
Okay, so thank you. I think the one important question which you need to read from your book about the management of this child, when a laxative is needed and for how long laxatives are needed, and what about parental education and the importance of diet. So these are three important things. I think we'll not go into that details because of paucity of time, and you need to read that definitely to complete this case on primary constipation.